do better. We will have an interesting group of 4 presentations highlighting different aspects of breast tests. We start out with Johann Hammer, mistakes in hydrogen breast testing and how to avoid them. Johann Hammer happens to be my brother and therefore the same family name. And he's working at the University of Vienna because Graz, our hometown, is too small for 2 Hammers in gastroenterology. So he, as the younger one, he had to leave and find his luck in Vienna.
Yes.
Hannes.
Thanks for the introduction. Thanks to Mark, who isn't here right now, for the invitation. These are my declarations that carboception app I will mention at the end of my presentation. The name of my talk comes from a UEG education initiative called Mistakes in, and deals with different topics in gastroenterology. And we, Heinz, Mark Fox, and I have joined this initiative with a Mistakes in the Management of Carbohydrate title in 2020. And I will summarize these mistakes later in my talk. But first, a little history. Why are we doing breast tests? And I think more or less it all started in the end of the 1960s with this seminal work by Michael Levitt, published in New England Journal of Medicine, who showed that there is a linear relationship between the hydrogen that is produced in the colon and the hydrogen that is excreted by exhalation on the other hand, and therefore the H2 concentration in expirated air represents the H2 concentration in the colon. Another seminal work by the late Alan Hoffman, who died just a couple of months ago, sadly, shows you why we are mostly using the H2 breast test, because the sensitivity and the specificity were much better than, in comparison, the oral glucose test with a poor sensitivity and a specificity that is 96%, so not too bad. And this study was done in a small group of subjects, 25 patients who were known to be lactase deficient and 25 patients who were known to be not. But the problem with this test is shown in this review, again from Michael Levitt, but in the 2013 to be exact, that shows that lactose-reduced diet has mixed results when we look at symptom improvement. You see that overall symptom improvement in these studies, 4 studies have looked at that. Only in one we have found an overall symptom improvement, but 3 others did not find improvement. And also in special symptoms like abdominal pain, diarrhea, and flatulence, some studies showed an improvement, others did not. So there is a problem in the relation between malabsorption test and the result of lactose-reduced diet. Therefore, we formulated 10 questions and 10 mistakes that can be found in relation to carbohydrate intolerance, and I will go through all these questions in the following minutes. Mistake number 1, failure to distinguish food intolerance with food allergy. You all know when we are taking history from some of our patients and we ask them, do you have allergy? And they might answer, yes, I have lactose intolerance. And I think it's very important to teach the patient the difference between allergy on the one hand and intolerance on the other hand. And of course, allergy is dose independent. Obviously, there is a reaction of the immune system And if we suspect allergy, we can do allergy tests. And finally, treatment is strict avoidance of allergens, while in intolerance, the treatment is a reduction, but not strict, most of the time not a strict avoidance of the incriminated carbohydrate. Next, two mistakes I want to summarize are two, not considering the mechanisms underlying the relationship between food ingestion and symptom development, and three, assuming that these mechanisms are completely understood, because they are not. The mechanisms that might be involved in food intolerance are different. There are, on the one hand, of course, maldigestion or malabsorption. There is also a physiologically incomplete absorption, and we have talked about the FODMAPs previously. In IBS, we also often talk about a dysregulated handling of bowel contents. And there is also a reaction to the products that are produced during digestion, like in histamine, like short-chain fatty acids, or gas, for instance. And there might also be a sensitivity to food contents or food additives. And finally, of course, not to forget, there might be a concurrent medical or psychological condition involved in food intolerance. And food intolerance are very frequent, and a recent study done in several countries in the world showed that approximately 11% of the world population have some kind of food-related complaint. So although this problem is so frequent, the education of our medical students and postgraduate education is rather poor, and that is a problem on the one hand as a diagnostic problem and also a problem for treatment. Next mistakes we have formulated. Number 4, putting too much trust in breast testing. You heard that in the morning already. And 5, misinterpreting lactase deficiency or lactose malabsorption as lactose intolerance, because lactose malabsorption is not the same like lactose intolerance. And you can see here 2 typical patients. Both patients qualify as lactose malabsorbers. You see that in the rise of the blue line from baseline during the next 3 to 4 hours. But the person on the left has also symptoms, while the person on the right did not develop any symptoms at all. And I have summarized our results from the adult population and also from the pediatric population here. And as you can see, in the adult population, approximately 35% of the patients who had malabsorption did not qualify to be intolerant, so they didn't develop symptoms. On the other hand, among those who had symptoms during the test, only approximately 50% also had malabsorption. And the numbers are similar to in the pediatric population. And here you can see data from the pediatric population. And when we wanted to correlate the results of the breast intolerance test with clinical symptoms, you can see that the children who had malabsorption and those who did not have malabsorption had the same clinical symptoms. Both overall symptoms were not significantly different, as well as individual symptoms like pain, flatulence, meteorism, and so on. On the other hand, when we divided the group into those who had symptoms and those who did not, those who had intolerance had much higher, much more prominent clinical symptoms in the year before the study, before the breast test. Next mistake, number 6, relying on unvalidated symptom assessment. You've heard that again in the morning. There was no validated symptom questionnaire available for specifically developed for breast tests, and we have done that and have developed 2 symptom questionnaires for the adult population and for the pediatric population. We call them ACPQ and BCPQ, and both kind of questionnaires had good psychometric results. Next mistake, number 7, not considering the role of FODMAP intolerance, and 8, ignoring the influence of comorbidity. You can see here nice pictures from very well done studies from England, where they have shown that different FODMAPs have different physiologic effects in the gastrointestinal tract. In the upper pictures, you see that after the monosaccharide fructose, fluid is accumulating in the small intestine due to osmotic fluid influx. While after fructanes, that qualifies as the O in the FODMAP, the oligosaccharide and polysaccharides, there is hardly any fluid influx in the small intestine, but there is a gas production in the large intestine. So that would suggest that different FODMAPs, different carbohydrates, induce different symptoms and induce different physiologic changes. And we have looked at that at last year's UEGW, and we have compared the symptoms of lactose ingestion versus the symptoms of fructose ingestion in the same person. And we have found the probability to develop symptoms with either carbohydrate was only 25%, while 40% of the patients developed symptoms with only one of the carbohydrate, with lactose or with fructose. So it makes sense to test different carbohydrates before a diet, a specific diet. Mistake number 9, overlooking the dose dependency of symptom development. And again, a table from the review of Mike Levitt from 2013 shows that symptoms occur in adults only when they ingest a high amount of lactose, and lower doses of lactose, like 12 grams of lactose, most of the patients accept that and tolerate that. And another study with 13C lactose digestion shows again that even maldigesters digest some of the lactose ingested. You see that after C13 lactose challenge, the patient, there is a rise in C13 glucose in the plasma as a sign for some lactose digestion. And you also can see the dependence on the dose for both malabsorption and symptoms in another group from China. You see on the left that the more lactose you ingest, the higher the percentage of lactose that is maldigested, and of course, the higher is also the lactose-induced symptoms. And in general, we say that the tolerance of lactose in milk, of course, is individually different. And on the other hand, the tolerance of milk is higher when consumed with other foods than when consumed alone. And lactose in milk is tolerated much better than lactose in watery solution. And usually, even malabsorbers tolerate up to 18 grams of lactose when ingested over the day. And some malabsorbers even tolerate up to 70 grams of lactose per day when divided doses may be eaten and consumed with foods, with other foods. And to show the patient, to teach the patient how much of the carbohydrate can be tolerated in this patient, in this individual, we have developed a carboception app that allows the patient to test different carbohydrates and different doses and to learn how much he or she can tolerate. But only available in German at the moment, and only available in Germany and Austria at the moment. The last mistake I want to tell you is omitting professional dietary counseling and follow-up. An easy lactose intolerance doesn't need a dietitian most of the time, but most of the time there is no easy lactose intolerance, but more extended diet should be recommended, and then a dietitian is very helpful, and the dietary counseling must consider also the supply of nutrients which may be affected by long-term adherence to a specific diet. And again, I want to go back to the carboception app because it allows also to test different FODMAPs to be tested before you introduce a FODMAP diet, and it's much easier for the patient not to start with a full non-FODMAP diet, but only with those specific carbohydrates they don't tolerate, seen by symptoms. Thanks for your attention.
Thank you. Questions? Yeah. Ram?
I just wanted to ask you on practically, what are symptoms during the test? How do you define them? Diarrhea, abdominal pain, bloating? I mean, I wanted to guide my laboratory personnel and say, okay, you got to record symptoms, but how many symptoms? 1, 2, 3, to define the positive test. And the second issue is, what about those patients that have symptoms but not any rise in the hydrogen concentration? So what do you think about them? What kind of a people are they?
Both are very relevant questions, of course. And in our validation process, the qualification of a symptom as carbohydrate induced was a big discussion, of course, and we came to 4 symptoms that are relevant for carbohydrate ingestion on the one hand, and also relevant in clinical terms, and that were abdominal pain, flatulence, meteorism, and diarrhea. The patients ask us to include nausea, and you can't. We hardly could go without nausea in the patient. They wanted nausea in the questionnaire. So we included 5 symptoms finally in the final questionnaire. We didn't include, for instance, borborygmi, because it seemed to us not very clinically helpful and relevant. We apply the symptom questionnaire every half hour, like we do the H2 breath test, and a rise over baseline of 20 millimeters in the 100 millimeter scale is an indication for symptom, for a positive test. And I recommend to use a validated symptom questionnaire over using your own symptom assessment because it is not that much prone for bias. The other
question is about those that have symptoms but not rising gout.
Yes. That's a very important question, and we need to do studies with them. At the moment, we have the maldigestion or malabsorption as a basis for our diagnosis, and can recommend treatment for those who develop symptoms. And of course, the big group of those who have symptoms but no maldigestion is still a question to be answered, what to do with them. Of course, measurement of methane might be helpful, I guess in only a small group in these patients, but also other measurements, also nocebo effect should be included in the diagnostic procedure.
Because if they are methane producer, I understand why the hydrogen is not going out. But if the methane is also negative, I think we have to consider them like in DGBI patients and think about neuromodulation. I don't know.
Yeah. They might have a hypersensitivity in the gastrointestinal tract. They probably do. Most of them are IBS patients. But we have to do some research to find out if they can benefit from lactose free or a lactose reduced diet or not.
Ishairon from Tel Aviv, Israel. Well, in continuation to Rama questions, I spoke to Douglas Drossman, and he, offhanded me and said everything is IBSD. Those patients, have nearly a complete correlation with the symptoms. If you do Rome 3 or Rome 4 questionnaire, probably most will supply you the questionnaire of IBSD. Mm-hmm. Now, in those cases that you eliminate completely for at least 2 weeks lactose, and you don't get a real symptom improvement, would you recommend doing some test for hypersensitivity or visceral hypersensitivity in assessing IBS or something? Because this is an unsolved problem. Mm-hmm. We have the same problem with fructose intolerance, which is more complicated because you cannot omit all food containing fructose.
Mm-hmm. I would not recommend it actually, because when a person, for instance, especially for fructose, is positive in the test, so he has intolerance, but he does not have malabsorption, I'm quite sure that he is hypersensitive. So it more or less is a hypersensitivity test. If this person also is intolerant against lactose, maybe even against fructanes and whatever you test, he has hypersensitivity. You don't need any other test, and we don't do barostat tests or whatever in these patients.
But can I just add that that you showed on the graphs from the Nottingham group on the MRI that the fructose increases small intestinal water, that's independent of whether it's malabsorbed. So
Right.
that can induce symptoms without needing an actual fermentative
Yes.
event to occur.
Yes. And when you look at the time course of symptoms after fructose ingestion and lactose ingestion, it differs very much. Fructose indeed does induce nausea in some patients, but only in the first 30 minutes or so. Lactose doesn't. But pain develops, again, much earlier in fructose than in lactose. Lactose, after 60 minutes at the earliest. In fructose, pain starts within the first 30 minutes.
Could I ask a question then about how long do you wait for the symptoms? What's the length of time of observation? Because some studies would do it in a few hours, some 2 days.
Well, we do the symptom assessment for 9 hours. Why are we doing that? Because diarrhea most of the time doesn't develop within the 3 hours we do the breath test. Diarrhea, if it develops at all, it develops later in 6 to 9 hours. The problem with our test during 9 hours is that we send the patient home after 3 hours and he is doing whatever he is doing during the rest. So that is a problem, but at the moment, that's how we are doing the symptom test.
Okay, so thanks very much.
Thanks.
So we'll move on now to how can we optimise the lactose breath test by including perhaps C13 measurements from Kristin Verbeke from Leuven.
Yeah, doesn't work.
Yes, it does.
Of course it does, but not with in my hand.
Oh, that's weird. Okay. All the technology has suddenly collapsed. I've spent the last few moments troubleshooting. This is generally not working. How extraordinary.
The old turn it on, turn it off trick.
Yeah, I was
Didn't work.
thinking that, but it's not. Oh, okay. But what on earth?
That's why he is an engineer.
No, but I've been doing this the whole damn time, and all of a sudden, fecubonics is not yet the topic.
Excellent.
So thank you very much. Thank you, Mark, also for the invitation to be here. In our hospital in Leuven in Belgium, we have been performing lactose breath tests for many years, and we have always been using C13 labeled lactose. And so I will explain today what the impact can be on the results of the test. So, these are my disclosures, and I think I don't have to explain for this audience that lactose malabsorption is not a disease. As you can see, the majority of the people in Asia, in Africa, and in South America experience lactose malabsorption in adulthood due to the non-persistence of the lactase enzymes. And actually, it's only the Caucasians in Europe and in North America that remain lactose persistent in adulthood because of a single nucleotide variant in chromosome 2. But despite the fact that it is not a disease, it can be cumbersome and it can be problematic for the patients because lactose that is not properly digested in the small intestine gets fermented when it reaches the colon by the resident bacteria. And we get there the production of short-chain fatty acids and gases. So in this scheme, you can see that pyruvate is the central molecule in the fermentation. Or you don't see it. I can try if I can use the pointer. Voilà. So pyruvate is the central molecule from which propionate can be produced via the succinate pathway, and from which both acetate and butyrate can be produced here. Now, if you convert lactose into short-chain fatty acids, the osmotic load increases by approximately 8-fold. So that's quite a lot. And although we think that these short-chain fatty acids are rapidly absorbed by the colon, we cannot exclude that there is some local or temporal accumulation of the short-chain fatty acids that can draw water into the colon. However, Tao He calculated a number of years ago that if you completely convert the lactose into short-chain fatty acids, that would correspond with approximately 630 milliliters of water that comes into the colon, which is actually not that much, and which might not completely explain the symptoms that we see in those patients. The other thing is the hydrogen production. So there are, in this fermentation scheme, 3 reactions where hydrogen is produced. The most important one is this one here, where hydrogen is produced in the reoxygenation of reduced pyridine and flavonucleotides. Then we have here in the oxidation of formate to hydrogen and CO2, the production of hydrogen. And then here also in the reoxygenation of ferroxidin. So, but if hydrogen accumulates in an ecosystem, it will rapidly thermodynamically restrict further fermentation. So it is important that in an ecosystem, hydrogen can be dissipated. And in the human colon, there are 3 groups of bacteria that can consume the hydrogen. And we have the methanogenic archaea that have been talked about this morning already, that convert hydrogen into methane. We have the acetogens that convert hydrogen into acetic acid, and we have the sulfate-reducing bacteria that convert hydrogen into hydrogen sulfide. So the hydrogen normally can be dissipated through other reactions. But the hydrogen is actually the feature that is then used to diagnose lactose malabsorption. And actually the basis of the hydrogen breath test is one that hydrogen can only be produced by bacterial enzymes and not by mammalian enzymes. And second, that if hydrogen is produced in the gut, then that it appears rapidly in the breath. So if we see hydrogen in bread, it means that the carbohydrate has been in contact with bacteria. And that can be either in the small intestine, and then it is an indication of SIBO, or it can be in the colon, and then it's an indication of lactose malabsorption. But based on the test, actually it's not possible to make the differentiation. We will never conclude or use this test to diagnose or to make a differentiation between SIBO and lactose malabsorption. So hydrogen breath test is most often executed according to the guidelines, using a dose of a challenge with lactose, most often 25 grams. You can go up to 50, but I think that most people don't do that anymore. That's too much. We collect breath samples every 30 minutes for 3 to 5 hours. In our hospital, we take 4. And an increase in hydrogen of 20 ppm above baseline is indicative of a positive test. So normally, a hydrogen breath test works quite good, but the main limitation is that you can have false negative tests if you have people with a microbiota that quickly converts the hydrogen in acetate, methane, or hydrogen sulfide before it can be exhaled in breath. And so then I come to why we use the C13 lactose. So when you administer C13 labeled lactose, when it is digested in the small intestine, you get C13 glucose and C13 galactose that are absorbed and go via the port of circulation to the liver, or oxidized to C13 labeled CO2 that finally gets exhaled into the breath. So the appearance of C13 CO2 in bread is an indicator of lactose digestion. and we still measure hydrogen as an indication of lactose malabsorption. And then if I show you an example of a normal test, you see the C13 lactose appearing in the breads, and we say that the test is normal if we retrieve at least 14.5% of the administered dose in combination with an absence of hydrogen excretion, so less than 20 ppm above baseline. And then this is an example of a clear test of lactose malabsorption. You have a very low C13 CO2 excretion in breads and clear hydrogen, so this is not difficult. But what we often see is also such a test where you do not have, well, no CO2 does never happen. We always have a little bit of C13 CO2, but also no increase in hydrogen. If you would only measure hydrogen excretion, you would consider this as a normal test. But because we see here the low digestion of the lactose, we consider this as a lactose malabsorption test, and we assume that those people are the ones that rapidly convert the hydrogen into one of the other products. Now, to test, well, and to check whether this assumption is correct, we recently did a study in which we compared the combined bread test versus a genetic test. So we recruited 151 people, adults and children, a mixture, but we selectively enriched our cohort with people that had this difficult to interpret test, so low C13 CO2 excretion in the absence of hydrogen, to make sure that we could tell a bit more about that result. The patients then always provide 2 bread samples at each time point, and one series is then analyzed with isotope ratio mass spectrometry to analyze the C13 enrichment, and the other one is analyzed with a GC that is connected with 2 different detectors so that we can analyze hydrogen, CO2, and methane in one run. And then the participants also provided buccal mucosa swab for the genetic test, where we just checked for the specific single nucleotide polymorphism using a commercially available kit. And so then you can see that we had 88 adults and 63 children in our cohort, and about 1/3, 51, I thought, 50, were lactose non-persistent. Yeah? So it's clear that the lactose non-persistent, these are the ones with the CC genotype, have significantly more hydrogen than the heterozygote mutants, the CTs, and the homozygote mutants, the TTs, had hardly any hydrogen. The C13 excretion was also lowest for the wild type, so the CC, and higher for the TT, and the CT genotype had something in between. And the methane excretion was hardly different, was actually not different between the 3 groups. Now, if we only looked at the hydrogen excretion, then we can say that the overall performance of the hydrogen test was not too bad, actually quite good. We had a good specificity. The sensitivity was a little bit lower, which was due to the false negatives that we had expected. So of the 51 lactase deficient individuals, so the ones with the CC genotype, we missed 14 if we only looked at the hydrogen excretion. It's about 30%, which is what you can expect based on literature data. And if we then added the C13, so if we looked at the performance of the C13 CO2 excretion in the ones with a negative hydrogen bread test, then when we used the standard cutoff that we had been using always, 14.5%, then the sensitivity was good. No, the specificity was about 90%, but the sensitivity was only 50%. Now, based on this ROC curve, we could calculate a a better cutoff, and then that raised the specificity to 70%. But so by adding the C13 CO2 excretion, we could identify 13 of the 14 false negatives. So there is only one that, even with the combined test, still remained negative, but it comes with a price, and the price is that we have false positives. So that are hydrogen negative people that have a relatively low C13 CO2 excretion, but that have a CT or TT genotype, so that are lactase persistence. We also looked at what methane say, and in this cohort, methane did not provide any added value. You see it immediately from the RO curve, which means that it doesn't add anything to it. If we use the standard cutoff value of 10 ppm, which is found in literature, it only helped, it had a very low sensitivity. Of the 14 people that were negative with the hydrogen, we could only identify 2 that had increased methane. The specificity was good, but this is a very low sensitivity, so not very useful to add it. Based on the RO curve, we could calculate a more optimal cutoff value, but actually it's a theoretical value because you cannot measure below 1 ppm. And what this say is that any excretion of methane, however limited, would suggest lactose malabsorption, which is also not very useful. And you see it also in the results, sensitivity and specificity. Doesn't help you anything. So in this cohort, methane was not useful. So that brings me to the take-home messages. And so I think we can conclude that by combining C13 CO2 measurements, or by administering C13 labeled lactose instead of the normal lactose, you can effectively identify the false negatives on the hydrogen excretion, but the price is that you have a significant increase in false positive results. So I think it will remain a challenge for a clinician to decide, what do you want? Do you want to rule in all the people with lactose malabsorption so that you can give them the adequate diet or the advice to take some lactase capsules? Or do you want to rule out lactose malabsorption so that you can avoid unnecessary lactose-free diets, for example? And probably it will depend on the clinical setting and on the situation, which option you would prefer. What I also wanted to stress is that this cohort was selectively enriched in subjects with this difficult to interpret test, and so that we still need to perform the real-life performance of the test in a study that includes everyone, an all-comer study that does not select the participants. And finally, I would like to thank the people from the laboratory medicine department in our hospital where we analyze the tests, and our gastroenterologists that help with the interpretation of the results. And thank you, of course, for listening.
Thanks very much. And this is now open for questions. Can I ask the first one? Sorry.
The microphone? Oh, yeah.
Could I just quickly ask the first question is, we used, when we did a lot of breath tests, we used to use a lactulose initial test to see if they were non-hydrogen producers. Is that going to improve the outcome? And a second question is, how much does it cost to add the C13?
Yeah. So indeed, that would be an option as well. If you first do a lactulose test, then if patients are negative there, then you don't have to do a lactose breath test anymore because you know that the result will not be reliable, but then you don't know it. The advantage of this test is that that you can do it in one test.
Yeah.
It's still one test for the patient. It's a 4-hour test, and they don't have to do 2. So that's the main advantage. It is expensive. Until a few years ago, we used naturally enriched lactose, and that was because when I asked the companies for a quotation for C13 synthetically enriched, they say, we will not give you a quotation, you cannot afford it. So then the naturally enriched lactose was produced in Groningen in the Netherlands. They had a barn with cows that they put on a corn diet, and because corn is enriched in C13, the cows got enriched in C13, their milk was enriched, the lactose was enriched, and there was a company that isolated that lactose from that milk, which was also not very handy. We had to order 1.5 years in advance and so on. But now the cost of the labeled lactose has decreased, and now we can afford the labeled lactose. So we buy highly enriched lactose, and we mix it with unlabeled lactose to have a low enrichment, and we administer 25 grams. You need to administer the amount of lactose anyway to elicit the symptoms and the digestion and malabsorption. So it does not have to be that highly enriched. In Belgium, we are lucky that we have reimbursement for the test, because otherwise I think we would have to charge something like 70 euros to the patient, and I don't think they would pay it, I don't know. But now it's free. In Belgium, it's reimbursed.
How do you explain the false positives with the C13 breast test? Is there something wrong with their glucose metabolism, their C13 glucose metabolism?
I don't think there's something. I think it's just a kind of continuum. So you have the digestion, but we do not measure really the digestion. We measure something 4 steps further. It has to be absorbed, transported to the liver, oxidized to CO2, mixed with a bicarbonate body pool, and be exhaled in breath. And if you can have quite some variability in each of these steps that determine that the amount that you retrieve in breath, there is some variability in. And I think we somewhere have to put a cutoff value, but you could reduce that if you make the cutoff value a bit lower, you will have less false positives. So it's not that we have really a bimodal curve. It's too continuous.
As with any or most of the C13 tests, especially exception the HP test, there are several metabolic steps which end up between the pathophysiologic process you want to analyze and the thing you are measuring, that is CO2 in breast. So there might be several steps in there which are uncalculable. And I'm wondering whether with the special feature with glucose, whether diabetes and insulin might play a role, that an unexpected amount of glucose gets shifted into cells, converted to fat rather than being metabolized immediately.
Being oxidized, I think that is all possible.
Yeah.
Does doing the C13 mean they have to be in the laboratory?
No.
They can't do it at home?
No, it's just a powder. It's carbon-13, so it's a stable isotope. There is no safety concerns. There's no radiation burden, and we give it to the patients. They do it at home.
Yes, we used to collect it through blowing bubbles in.
Yeah,
liquid.
we use exotainers. We use the small exotainers,
Yep.
and you can just send them by post, and they get back to us, and we analyze them. So that's quite convenient. We do not use the big aluminium bags. No,
Yep.
they do it at home.
So any more questions?
Okay, thank you. Then we are going to the third talk, Jutta Keller on C13 breast testing for gastric emptying, a current role in patient management.
I'll close this one. And
I won't dare to touch the computer, otherwise it's my fault that the screen goes black.
Es geht mir nicht besser, heute Nachmittag. Ups, sorry, wrong button.
Golden fingers. Thanks a lot, Mark, and thanks a lot for the invitation to this wonderful congress on all aspects of function testing and dysfunction along the GI tract. I'm going to talk about C13 breast testing again for gastric emptying and the current role in patient management. These are my potential conflicts of interest which did not influence the content of my talk. The definition of the European Society of Neurogastroenterology and associated societies on gastroparesis defines gastroparesis as referring to a symptom or set of symptoms that is associated with delayed gastric emptying or severely disturbed gastric motor function in the absence of mechanical obstruction, and there are cardinal symptoms, meaning nausea and vomiting, and other dyspeptic symptoms which can also occur. If the definition requires the proof that there is a delay of gastric emptying or another severe disturbance of gastric motor function, you need to do testing to actually show this. So if you want to diagnose your patient with gastroparesis, you need to do some kind of motor testing, and in particular gastric emptying tests. For gastric emptying, scintigraphy is the reference method. There are some preconditions. It's suggested to use a meal with radioactively labeled solids to have a standardized protocol. The patients need to consume the meal completely. We need prolonged measurements for 4 hours. And normal gastric emptying means that 90% of the radioactivity has left the stomach after 4 hours. This is shown in this patient with all the radioactivity being in the stomach directly after consumption of the meal and none left after 4 hours. Whereas in this patient with delayed gastric emptying, there of course also is all the radioactivity in the stomach at the beginning of the test, but at the end there is still 43%, which means delayed gastric emptying and severely delayed gastric emptying in this patient. There is an alternative to scintigraphy, which can be used in the clinic. The C13 gastric emptying breast tests, which are not associated with radiation exposure, something which Kristin has already alluded to, which can be done repeatedly and on-site, even at home, if patients take it with them. The underlying methodologies are actually rather complex, but the tests are easy to perform. The subject has to ingest the C13 marked substrate. Usually it's orally, sometimes it's given intravenously. Then C13 CO2 is released by mainly hepatic metabolism, and it has to reflect the digestive or metabolic process that you want to investigate to be useful as a C13 breast test. C13 CO2 is then absorbed into the bloodstream and transported to the lungs and exhaled, and you can either collect it in these glass tubes if you want to perform mass spectrometry, or you need larger aluminum bags if you want to measure it via infrared spectroscopy, but both of these have been validated, the mass spectrometry being the reference method. And then you get a C13 exhalation curve over time. There are limitations. Most tests are not commercially available, at least not in Europe. The equipment is rather expensive, although compared with other methodologies, it's okay. And the patients have to sit around for several hours for most tests to really get these exhalation curves. You need the space, the patient needs to be patient, and so on. The C13 gastric emptying breast test in particular has been invented actually by the Leuven group from Gothenburg, published in 1993. This group used C13 octanoic acid for labeling of the solid part of the meal, but you can also use C13 spirulina plantensis, and this test is commercially available in the US. It actually also has a CE mark. It could be marketed, it would be legal in Europe, but it doesn't. And if you want to measure gastric emptying of liquids, C13 acetate is a substrate you would most certainly use. The principle of the C13 octanoic acid breast test is that if you ingest C13 octanoic acid with the meal consisting, according to Gose et al., of 2 slices of white bread, 5 grams of butter, a little water, and an omelette, and this is where the C13 octanoic acid comes in, the yolk is doped with the C13 octanoic acid, and there are some lipophilic bindings, which means that as long as the egg is in the stomach, the C13 octanoic acid sticks to the egg. But when the egg leaves the stomach, the other lipids will be split and absorbed so that the C13 octanoic acid is liberated, and then it is absorbed quickly via the duodenal wall, and it goes to the liver via the venous blood. And there it undergoes beta oxidation, which results in production of C13CO2, which then is absorbed into the bloodstream, goes to the lung, and is exhaled. This is our normal curve for healthy subjects who ingested this test meal. And this is an example for rapid gastric emptying, and this is from a diabetic patient with gastroparesis with very slow gastric emptying. And you can see the differences between the normal ones and the accelerated and delayed ones, but that's not how we usually investigate and how we analyze the curves. Instead, Gauss suggested a nonlinear regression, which is the formula is up here. And the resulting curve is inversely related, but analogous to what you expect from a scintigraphy. And the resulting t-half is then corrected by the time which is needed for the absorption and the processing of C13 octanoic acid, which roughly means that you subtract round about 1 hour from the resulting t-half to get something which resembles scintigraphic gastric emptying. Gauss did so in his initial study. He labeled the meal dually with a radioactive label and with C13, and he showed that the resulting gastric emptying half times correlate very well, and he had high sensitivity, specificity, positive and negative predictive values, which all exceeded 94% for his patient group. This, in addition to this form of analysis, which actually relies on the shape of the curve, there are other methods suggested how to analyze a C13 breast test. For instance, the generalized linear regression model, which picks certain time points at which the breast samples are collected. And from these time points, a gastric emptying half-time is calculated, which reflects absolute C13CO2 excretion. And other people use the Wagner-Nelson method, which reflects the manner in which C13CO2 appears in the venous system based on the pulmonary excretion rate. All of these have been validated against scintigraphy. There are some caveats regarding demography and influences this might have on the test, but for adults, most studies show no overall effects of age, gender, and BMI. Some studies suggest a tendency to slower gastric emptying in women, faster gastric emptying with increasing age, and faster gastric emptying in obesity, but these effects are actually minor. For children also, the largest study with children from the age range of 1 year to 17 years showed that gastric emptying of solids is getting faster with increasing age, but not gastric emptying of liquids. And there was no difference between boys and girls and no association with BMI in this group. Diet has an influence. You've already heard from Kristin about these cows ingesting corn. Corn is one of these C4 plants which use C4 photosynthesis and therefore enrich C13 in their stuff. Consumption of either pineapple, broccoli, corn, or sugarcane, these C4 plants, will result in a higher basal C13 excretion, and all the results of these C13 measurements are calculated against this basal value. So this basal value will heavily influence your resulting curve. And this is why these C4 foodstuffs need to be avoided at least 48 hours before breast testing. Physical activity will also influence your breast test results because even low physical activity increases CO2 production considerably. It's roughly doubled when walking in comparison to sitting. And physical activity has therefore a major influence on C13 CO2 excretion. These are two groups of medical students which we convinced to consume the C13 octanoic breast test. And this group was sitting throughout the measurements, and this group went back to the ward and just walked around a little. They didn't exercise, but they did their normal work on the ward and sampled their breath in between. And you can see the huge difference. You have to standardize for this. Patients must remain inactive, which usually means seated throughout the test. There are concurrent diseases and medication because the C13 breast test is an indirect test, and there are multiple steps in between before C13 CO2 is exhaled. Therefore, disorders of absorption, hepatic metabolism, and pulmonary excretion might influence the test results, but there have been several studies on this, and you need to have end-stage lung or liver disease, actually, to really see an influence. Otherwise, test results are quite stable, even in patients with some hepatic or pulmonary dysfunction. There are drugs with relevant effects on GI motility, such as prokinetics, of course, but also opioids and spasmodics. They need to be discontinued if you need to know how the stomach works without these drugs. But if they are essential long-term medications, it doesn't actually make sense for your individual patients. So for these patients, we just leave them on the medication and try to find out how their gastric emptying is under medication. And you also will continue the medication or do 2 tests, which you can easily do with C13 breast testing to monitor the effects of the drug if you're interested in. The C13 gastric emptying breast test performed for clinical reasons have to adhere to strictly standardized study protocols, because everything you change will influence your test results, and you either have to have your own normal healthy population and your own normal values, or you have to stick to the published and validated protocols. And this refers to the preparation of the meal as well as test performance and evaluation of results. The European guideline on C13 breast testing will give you protocols for adults and also for children, which have been validated against scintigraphy and where you can see how to perform them and how to interpret them. And if you do this, if you have a validated test, the clinical role of C13 breast testing is actually that they are an accepted alternative to gastric emptying scintigraphy, both in adults and children. However, this is actually only one side of the medal, because there are studies questioning why should we do gastric emptying tests at all. There is only a weak association between gastric emptying velocity and dyspeptic symptoms in many studies. There is an overlap and change over time between functional dyspepsia with normal gastric emptying and gastroparesis with delayed gastric emptying. Patricia and have shown that about 40% of patients classified as functional dyspepsia at baseline are classified as gastroparesis with delayed gastric emptying after 48 weeks and vice versa. And maybe most troublesome from a therapeutic point of view is that there is a questionable association between improvement of gastric emptying velocity and symptom improvement with gastroprokinetics. This you can see, for instance, from this meta-analysis from the group of Michael Camilleri. This is the improvement in gastric emptying time, and this is the improvement in upper GI symptoms, and you can see there is no significant association. However, in this analysis, all studies were included with multiple methods for gastric emptying measurements, various symptom instruments, and diverse treatments. Whereas when they limited the studies which went into the meta-analysis only to those performed with optimal testing, and optimal testing means scintigraphy, obviously, but also C13 breast testing, they did see such a significant association. And this was actually also shown by a recent meta-analysis by Göhn et al. From the Leuven group, who also saw a significant, and okay, it's not perfect, but actually it's quite strong, the 0.463 association between acceleration of emptying and improvement in symptoms if they included studies performed with optimal testing, including breast testing. However, what we need to keep in mind if we perform such a test, a C13 octanoic acid test or spirulina platensis or acetate, we do not test the gastric emptying, because that's complex. Liquids will be emptied following a more or less exponential emptying curve, whereas solids need to be titrated before they can leave the stomach to a size of usually less than 2 millimeters, and then there will be a more or less linear emptying, and undigestible solids will remain in the stomach until the interdigestive phase 3 motility recurs. We have further looked into this, and these are still unpublished data. We have investigated 302 dyspeptic patients who underwent both C13 acetate breath testing for liquid emptying and octanoic acid breath testing for solid emptying within 2 weeks. And you can see that both tests were normal in more than around about half of the population. Both were accelerated in only 3%, and both were delayed in only 1%, meaning 3 subjects in all of this. One test was delayed in nearly 20%, and one was accelerated in around about the same amount of patients. And in 3% of the subjects, we had opposite results. One was delayed, and the other was accelerated. And we further went on to analyze how these different patterns of liquid and solid gastric emptying were associated with symptoms. And only in patients with delayed emptying in at least one of the tests, this subgroup, symptoms were associated with gastric emptying delay. This means that if you measure liquid emptying of solids and liquids, they are often different in more than 40% of our population, and may be complementary and identify patients with different pathomechanisms leading to gastric emptying disturbances and symptoms. And there certainly are other factors which mainly and heavily contribute to symptoms in gastroparesis and decreased quality of life, such as other disturbances of gastric function, impaired fundic relaxation, impaired gastric sensitivity, but also, of course, impaired central processing, comorbidities, which psychological comorbidities in particular are those by themselves reducing quality of life, such as diabetes mellitus. And something we also often forget about, it is highly unlikely if you've got a cause for a severe gastric motility disturbance that this disturbance only affects the stomach. It will probably also affect the upper small intestine and maybe even further parts of the GI tract. So, and we've got another reason to believe that gastric emptying does play a role, a rather hard endpoint, which is mortality. It has been shown that gastroparesis, as defined by C13 breath testing, is associated with increased mortality. It is this test, this French study performed by Gosserol and colleagues in more than 1,500 consecutive dyspeptic patients. Delayed emptying was defined as gastric emptying half-time of above 200 minutes, and you can see that the survival curve is significantly lower in those with gastroparesis compared to those without. And they also performed multilinear corrections and showed that gastroparesis, diagnosed according to gastric emptying breath testing, was associated with increased mortality independent of age, gender, or diabetes status. To conclude, the gastric emptying measurements alone do not fully explain symptoms in patients with dyspepsia and gastric dysfunction. Impaired fundic relaxation, gastric sensitivity, central processing, but also comorbidities and infection of other segments of the GI tract contribute. But I advocate to not throw out the baby with the bathwater, because emptying tests, maybe for various food consistencies, can clarify part of the pathophysiology. And if you want to know about gastric emptying, C13 gastric emptying breath tests are a valid alternative to gastric emptying scintigraphy for measurement of gastric emptying velocity. They can be safely performed in adults and children. The tests have to be performed, however, according to standardized protocols in adequately validated representative patient populations, and this refers to the meal, the test performance, and evaluation of test results. And with this, I thank you for your attention.
Yes, Mark, could you bring the microphone back there? I might, before you get the microphone, I might raise a question. What do we know about the value of gastric emptying tests as a marker for response to treatment? And does treatment response related to then, if you have gastroparesis, does acceleration of treatment of gastric emptying result then in symptoms? What do we know about this whole complex?
Yeah. We know that the acceleration of gastric emptying does not explain all of the treatment effect, but it is associated. There is a significant association if you limit your analysis to studies with optimal testing facilities.
Yeah.
Thank you very much for this nice lecture. I would like to ask you, there are a few parameters which are included. I mean, not only the half emptying time, but also lag phase or T-lag. In your opinion, does it have any clinical meaning? What are the value of a normal T-lag? I mean, it has been considered as a redistribution phase, or a trituration or whatever with the food.
Yeah.
This is the first question. The other question, in those with cardinal symptoms, especially vomiting patients with severe gastroparesis, how can you complete? I mean, if the patient is vomiting or unable to finish the meal, would you abort the test, or would you take into consideration whatever they were able to eat?
Yeah. I'll answer the second question first. To take into consideration the amount the patient has consumed, that's difficult, because we have no extra normal values for diminished test meal, and this will influence gastric emptying velocity, of course. We tend to perform the liquid emptying test in these patients predominantly, because they will usually be able to drink 100 or 150 milliliters of our test solution. And we try the gastric emptying octanoic acid breath test, and we will analyze the results if we've got a major part of the exhalation cup, but we'll stop after they've vomited. We'll extrapolate baby, and that's only a qualitative assessment only, so we no longer can really quantify gastric emptying time. And for the first question, the lag time, the test I've shown you, or we use for cystatin acetate breath testing, it actually analyzes the time needed until maximal cystatin exhalation, which is the lag phase, equivalent to the lag phase. So it is used. It is an additional parameter, but it was not more informative than gastric emptying half time in our analysis. That's why I left it out for this presentation. Yeah.
Hello there. My name is Alex Menez. We've spoken a couple of times. Can you please work through an intellectual question I have, bearing in mind my complete and utter ignorance of breath testing? So I work on MRI of gastric physiology, and MRI is exquisitely good at looking how the bowel contracts, accommodation, and the duodenum. It's kind of rubbish at looking at transit, because you need to lock the patient in the MRI scanner for 2 hours, 3 hours, and everyone then kicks off about it costing too much money. My interest in breath testing is it can mesh together very nicely with a short MRI scan that can be done in 20 minutes. It can be very affordable. And it comes down to health economics for me. If this breath testing can be done for even €100 or something cheap, the MRI can be done for another couple €100, and you might be able to bring together a meaningful, holistic gastric physiology test. And do you see a world where that could happen? And do you think that'd be more useful?
Yeah. I wasn't aware of the fact that MRI is bad at discriminating gastric emptying times. I always saw the disadvantage of having the patient in the machine for a prolonged period of time, but it could if you can afford it.
Yes.
Yeah, okay.
So just to be very clear on that, gastric MRI is very good at transit time, but the MRI is a workhorse. It generates a lot of revenue, especially for our American colleagues. Yeah. And it's just a misuse of that technology to try and do a transit test with a solid meal in that setting.
Yeah, but it could work well. Yeah, patients have to move somewhat to get out of the machine, but this could be limited, and otherwise it could work well. Yeah.
Okay, but I'm specifically a short test where the person does the hydrogen breath or the carbon breath test, and then you do a short MRI, and the whole process time could take more than 30 minutes. Can we move towards that, do you think, in clinically meaningful timescales?
Yeah, maybe, because both are already standardized. So to combine them shouldn't be the effort. Yeah.
I can comment on that. We've done all this kind of thing in Zurich, and the difficulty with transit time and MRI is you have to be very subtle about this, because the amount of secretion that gets produced affects the volume in the stomach, and then you don't know what's emptied and what's in the stomach in terms of the nutrition that you've given. Whereas scintigraphy has the huge advantage that you're only labeling the food. And this sounds a technical point, and I guess it is, but that does impact on these things. And if you did do that test that that Alex described, you'd have to do special measurements of concentration, and that can only be done with liquids. So there are significant technical hurdles to overcome. But I will say one thing. I've done hundreds of these tests, and I've never seen anyone. I've seen very, very few with true gastroparesis. What we most often see, we almost always see about 10% of the gastric meal has emptied from the stomach before we even start the measurements, because they've got to drink it, and they normally do that in the sitting position. Then you get them into the machine. It only takes 5 minutes, but they've still emptied 10 to 20%. We see that also in scintigraphy. The reason that you don't know this is because normally they normalize the volume or the concentration or the scintigraphic marker after they finished eating, therefore ignoring the emptying that's already occurred. So gastric emptying is a far more dynamic process than one imagines, except perhaps in people who've got an obstruction at the pylorus. So we have combined these things, and we tried to make breath testing work to try and measure this early emptying and then this dynamic change. And we failed, probably because of these multiple steps between the ingestion and the excretion of 13C.
Yeah, it's definitely more complex than it looks like if you just have a look at the curves. But from the emptying curves, you do get, it's not a 2-point measurement. You have the time curve that you can analyze, and we do certainly see patients with delayed gastric emptying with clinical consequence, no doubt. Yeah.
No, I'm not doubting that, and I do think, and we've just actually tried to publish, and I'm sure we will publish it, where we've managed to get that same result with 13C in a large sort of 400 people cohort. Yeah.
Can I just quickly ask about what happens for the people who don't like eggs? Have you validated other alternative solids?
No, we offer the cystatin acid. We didn't. The cystatin spirulina test also includes egg. It's also egg-based. So if you want to have one of the two methods which are best validated, you will have to consume the egg. Yeah. Or you change to cystatin acetate and measure liquid gastric emptying.
And do you add pepper and salt to the eggs? That's what.
They could apply some salt and pepper if they want to, but we actually explain, because the real problem is that they may taste cystatin octanoic acid. It's not as bad as the short chain, but it's also medium chain, and it doesn't taste well. And some people really dislike it. But we explain it's a medical test. It's not a nice hotel breakfast. It's a medical test, and they just have to.
So our nutrition scientists in Zurich produced a 13C octanoate muffin, egg-free, but still quite nice.
I'm wondering about the osmotic change you would induce by using salt, or the capsaicin effect of pepper. And the capsaicin of pepper, I don't know what that
just
would...
a little bit. No, we don't allow it. We don't give it to them. They just to consume it. Yeah.
Kids with porridge, not with egg.
There you go.
Contains the same amount of calories that we use for solid emptying of the stomach.
That sounds like quite a good solution.
So you can have porridge, muffin, or omelette. Is that
porridge
right?
is semi-solid.
The problem with all of this is it's really a dilemma. Every meal, because they're all different in consistency and or calories and or composition, technically needs to be validated in itself. They're not interchangeable. That does really make stuff troublesome, doesn't it? Yeah.
Okay. Well,
otherwise, people just have to eat and to collect breath samples. That's really easy. Yeah.
Thanks very much, Jutta. Now we've got a online,
do.
is that right?
We do. We have...
So,
Oops.
So Heinz Törnblom from Sweden, from Gothenburg, is going to tell us about water and nutrient drink challenge testing and what it actually tells us. So we look forward to that.
Oh, hang on.
Hello, everybody.
Interesting.
Hello.
Hello, where are you?
Can you... This worked last time.
Please wait another minute. We are having some technical issues there. We cannot yet see you on the...
No, he's not. Is he... Hans, are you there? No,
I've heard him already.
No, that was him talking here.
Oh, yeah.
You've got the volume, but the projection hasn't happened.
Yeah, we are working on the projection.
Or is he
It's
live?
pre-recorded.
Oh, it's pre-recorded.
So you won't answer.
Hans was hoping to be here, but then he couldn't, and he's recorded this talk for us. Ah, there we are.
There he is.
Where was he hiding? Yeah, because there's the double.
My name is Hans Törnblom, and I'm working at Sahlgrenska University Hospital in Stockholm, Sweden. I would like to start thanking the organizers for inviting me to give this talk with the topic Water and Nutrient Drink Challenge Testing. What does it tell us? And I also want to say sorry for not being able to attend in person, since I know that you are all visiting a very beautiful city, the city of Ascona. These are my conflicts of interest. To start with, there are a number of different types of drink tests reported during the last 25 years.
1 second.
The intention has been to find a simple, more non-invasive means of assessing gastric sensory motor function. This topic was covered in a recent review made by the research group led by John.
Do forgive me. How interesting. Is it on a double? Is it on the double screen?
No, I think it's the video like that.
No slides.
I think the video doesn't have the... No. This is my mistake. I'm so sorry.
Hello, everybody. My name is Hans Törnblom, and I'm working at Sahlgrenska University Hospital in Stockholm, Sweden. I would like to start thanking the organizers for inviting me to give this talk with the topic Water and Nutrient Drink Challenge Testing. What does it tell us? And I also want to say sorry for not being able to attend in person, since I know that you are all visiting a very beautiful city. Glasses.
So, everything was working very smoothly until about an hour and a half ago, and since then, all computers have been against me. Now, I'm sure what Hans has got to say will be eloquent and good, but he's clearly referring to slides that we cannot see. And so, we have a few real experts and people who use this technology regularly here, and I'm happy to play this recording. Or, if you prefer to have an open discussion with experts in nutrition and breath tests, then I'm very happy to also allow Heinz, and to contribute myself, of course, to such a discussion. Who would just like to hear Hans? What Hans has got to say about these tests? I'm sorry to say I should have checked when I assumed. Well, I did make sure it was running, but I must admit I assumed he was just going to flick to the combined visual cues, and I didn't check the whole thing through this morning. Or who would prefer the guided discussion? So, guided discussion?
I think so, yep.
All right. Okay, let's do that then. So, I've got my gelato somewhere here. Maybe, if I may take the prerogative, and to start the discussion. So when it comes to gastric emptying studies, what we felt in Nottingham at the time was that we weren't doing a great job and that we moved across to the following model, which I shall explain to you very briefly. So we said, number one, the problem with the egg beta meal is that on a technical level, it's really questionable. Only a part of the meal is labeled. It's rather small in volume, about 250 milliliters, and although it's well validated, the associations with symptoms, although they are present, are not massively convincing, and particularly not in the population that we often get referred. That's talking about us, which is like your functional dyspeptics, where of course here's the killer observation I would throw out here. When do your patients complain of symptoms? Do they complain of symptoms 2 or 3 hours down the line? Or do they actually complain of symptoms directly after the meal? If you're talking about functional dyspeptics, it's directly after the meal. If you're talking about diabetics and maybe Parkinson patients, well, then I'm still feeling full 4 hours after the meal, I have volume regurgitation and maybe sick. And this, I believe, is the group that's driving the association that Michael Camilleri and the other tests are showing. And by the way, that applies to my study as well with 13C. We had a whole number of people with Parkinson's disease in that project. So what we did was we validated the amount of volume. So you said, how much can you take? We validated this. 400 milliliters is enough to cause moderate fullness in healthy men and women, and is also a volume that can be tolerated by 95% of functional dyspeptics and gastroparetics without vomiting, of a meal which is like an Ensure drink in the normal standard thickness and calorie content. So we use that labeled. It labels beautifully because it's got lots of protein, and it's not eggy, it's not lactose, it's a neutral kind of meal. And this is what we used. And so I'm throwing it out there. So as a different kind of model, where we were measuring then the half emptying time, but because it's a liquid, we could also measure this early phase and late phase emptying. So I'm throwing that out as a different kind of way of using the scintigraphy, or indeed MR, whatever type of project. It's just changing the method, just changing the meal. So I'd be very interested to hear what people thought of that, but also, do we have to do solids and liquids? Do you think that they're completely different? Do they empty the same or different?
Comment back there. Yeah, and thank you. But please wait for the mic.
It may not surprise many or some of you that know me to hear that I've got an opinion on this, but I think we can go one further than solid or liquid and bring in calories to that, because I think that's a big part of it. And still a very brief story. MR enterography is used with MRI once again for looking at Crohn's disease to distend the bowel, and something like PEG or mannitol is used to stop that water being absorbed. And the output, or the result of that, is high levels of prokinetic activity, that is contractions across the entire small bowel and stomach where it's left. And when I naively got into this space in circa 2015, we simply went with a water drink, 300 mils, to stretch the stomach and provoke contractile activity, which was far more interesting to us than transit. And we found that the stomach would immediately start contracting vigorously. And in people like Parkinsonian bowels, those stomachs had no problems contracting vigorously after that simple stretch challenge. And I think I got a lot of pushback unwittingly from people saying, well, it's not got solids in it, and it's not got certain amounts of fat and all the rest of it. But for me, the simple question was a neurological one. Does stretch cause contractions? And in someone with a myopathy, something like SIPO, we saw no evidence of contraction happening because the bowel couldn't contract. And so I think just to kind of continue this conversation and pass it back to you, Mark, do we actually, do we know what we're asking of the test? Is it interesting to know if that bowel can mechanically move around? Is it interesting to know, can it accommodate? And do you see the stomach stretching up, in different parts of it, which you can visualize easily with medical imaging? Or are you just focusing on the kind of the resonance time of that meal in the stomach as it moves through, which is, in my opinion, akin to something like constipation, where we're not actually interested in the bowel movement, it's more the pain associated with something upstream not working properly. And I feel there's more to unpack around these two challenges there.
While I walk to the next person, the contractility is the most boring measurement there ever was, because in almost everyone apart from the myopathy patients, it's always approximately 3 times a minute, and it's always present.
Yeah.
Well, in all of our dysfunctional dyspeptics, all of our diabetics, and except for the very occasional patient with a severe myopathy, I mean, I'm not saying it's uninteresting, but the frequency is uninteresting. I should be more precise. Did you really see it often not responding?
I think what we don't see is where does it start contracting from? Is it antral or lower down? And are the contractions occlusive or not? And that's completely different.
The question of occlusivity is complicated by the fact that the volume is different. If you've got a large volume, then it appears to be less occlusive, but of course the size of the contractions can be the same.
I think they're...
You just asked whether we think that it's important to measure both liquid and gastric emptying. And following our examinations or analysis of the patients to whom we just gave both tests, I think yes, yeah, because they may have just a delay in one of the functions, solid or gastric, and both affect symptoms. So yes, it is important.
Yeah.
So what about the third component, the MMC? Because the smart pill will measure that.
Well, I mean, the problem with the MMC is that happens when, for imaging, is that generally speaking, it happens when the bowel is empty. And so with imaging, it can be quite challenging to measure that, because it tends to happen when the stomach is almost empty.
But,
so
does it correlate?
Does it correlate with?
Does it correlate with the other measurements? Because the scintigraphy in the smart pill validation,
yes,
there was a correlation. So,
I think what happens is but with smart pill, it's not a nutrient, and you don't eat the smart bar until a significant time after you've swallowed the pill, but the timing from when you've ingested the pill to when the MMC3 kicks off, that is what you were measuring in that study. In someone with very poor function, like the SIPO people, which maybe Alex will put me right about the contractility thing in a moment, but in those people, you can wait a very long time till that happens. And so there will be some general correlation between gastric emptying time and MMC3 activity, but it is very much in the tough end of the spectrum, I would say. So Alex, just to push you, so you're saying you see plenty of patients in whom you don't see contractile activity?
Yeah, there is a group of people that is,
When we looked at SIPO back in 2013, we found there was almost 2 different types of SIPO patient. There was grossly dilated but hypercontractile loops that responded well to neostigmine, and there was some just completely dead, kind of flaccid loops that weren't moving at all and couldn't be nudged upwards, either with mannitol, as in to stretch it, nor with the neostigmine challenge. And as we've looked around the gut, we've also looked at post-surgical ileus, for example, and we see again there's a phenotype where things are moving around a lot versus not moving at all. And I think as we look at the stomach, there's diabetic patients where the contractility can mean something. Now, I think there's nuances in contractility. There is, quite aggressive contractions, there's asynchronous contractions, which we can't characterize particularly well with MRI, but you can see the total amount of movement. And I think I would even, in a regression analysis, limit it to is moving versus isn't moving, just as a simple discriminator. I think very nuanced assessment is overkill, and it's difficult to do, but I think there is information locked up in there. Now, the question is, what does it mean in the context of the other things we can measure in the stomach?
15,
in sort of fairly healthy people, like the functional dyspeptics, you don't see. Do you still sometimes find people who've got not contracting?
To my knowledge, we have never done a particularly compelling study with MRI in that patient group, and I think we need to do that, but see my talk later on that topic too.
Okay, thank you. This was a nice concluding comment. We are 15 minutes into break anyhow, so thank you, Mark, for taking this initiative.
I'm sorry for the technical difficulty.